need an introduction. So tonight we're going to get our medical errors lecture from Dr. Roger Bertholf. So Dr. Bertholf was here for a really long time. So from 1994 to 2017, he was our clinical chemistry and toxicology director and point of care director at UF Health Jacksonville. And he got both his master's and his doctorate at UVA in Virginia. Go Cavaliers. And then ended up coming to Florida and started out in Gainesville and then came to Jacksonville. And in 2017, he left us. It was sad. He moved to Houston, and so he's now the clinical chemistry director at Houston Methodist Hospital and also a professor there as well, and the director of their clinical chemistry fellowship program. So he has more than 60 publications in clinical chemistry and toxicology, even more than that, more than 70 workshop presentations on various clinical chemistry and toxicology topics. He was the chair of the Florida Board of Clinical Lab Personnel. So if you may remember, he used to do our Florida Laws and Rules lecture when he was here as well. Luckily, he still has ties in Jacksonville. And so maybe we might get him to come back and do that again next year. We'll see. And so he is also the editor-in-chief of ASCP's journal Lab Medicine as well. So welcome to Dr. Bertholf. Oh, you got one. Okay.
Thank you, Yvette. It's a pleasure to come back to Jacksonville. As Yvette said, I was here for 22 years, and before I relocated to the Houston Methodist. And my tie here in Jacksonville is my daughter still lives here, along with my son-in-law and grandson. So yes, I do have reasons to come back to Jacksonville, and I hope to do it regularly. Let me get this in the right mode here. Do I cancel that, or is that all right? Okay. Whenever you invite a speaker from out of town, you got to expect that you're going to get a shameless promotion for their institution. So I'll try to get this through as quickly and painlessly as possible. I work for Houston Methodist Hospital, as I said. It, just like what is now UF Health in Jacksonville, it changed its name 3 times during the time that I was in Jacksonville. It was UM's University Medical Center. It was a Columbia Hospital at one time, and then it was Shands Jacksonville until they rebranded as UF Health in Jacksonville. And just before I moved to Houston, Houston Methodist also changed its name. It used to be the Methodist Hospital, or TMH. And I'm glad they changed it to Houston Methodist. Not only does it identify it as being in Houston, but I always thought places that start out their name with "the" is a little bit pretentious. And my apologies to any Ohio State fans here, but you know, it's not like there's only one in the world. But Houston Methodist is the largest healthcare system in the city of Houston, and Houston, you may know, is the 4th largest city in the United States. So it's a pretty extensive system. It's located in the Texas Medical Center, which is an area of Houston. If you fly into Houston and you sort of look at the profile of it, it almost looks like it's 3 different cities. You have the downtown business district with all of its high rises. You have what we call the Galleria to the west of the city, which has a lot of condos and a lot of business and things like that, and high rises. And then you have the Texas Medical Center, which also looks like a city as you're coming in from the air because of all of the institutions that are within it. And if I could just point all of this, and I was afraid that you wouldn't be able to see that, but let me see if I can. This entire overhead view here is the Texas Medical Center. Methodist Hospital is pretty much all of this part of it right here. It's the largest institution. It has about 7 different, what we call towers or buildings that are part of that system. But the Texas Medical Center also includes Texas Children's Hospital, the largest children's hospital in the world. It also includes MD Anderson Hospital, the largest cancer center in the world. It includes a couple of other large hospitals, one Ben Taub, which is sort of like the county hospital, what UMC used to be. And it has the Memorial Hermann Hospital, which is a hospital for UT Houston, University of Texas. And it's got a couple of medical schools, the UT and the Baylor medical schools, and then a variety of other institutions that are there. But a little bit about the Texas Medical Center. There's more than 60 medical institutions in it. About 100,000 employees commute to work in the Texas Medical Center, and I can vouch for that. There's about 10 million patient encounters per year, 180,000 surgeries, 750,000 ED visits, and a gross domestic product of about $25 billion, which would make it the 11th largest business district in the United States. But Houston Methodist is not just the hospital that is in the Texas Medical Center. It's actually a system of 7 different hospitals, soon to be 8. But we also have hospitals in Baytown, Sugarland, West, Houston Methodist Willowbrook, the Woodlands, and Clear Lake. And I'll just show you quickly. You can see in parentheses is how many beds each one of those has. The hospital where I work has more than 1,000 beds. These are, of course, smaller hospitals. The largest is Sugarland. The smallest is Clear Lake. And I'll show you on a map of Houston, the medical center is pretty much in this area right here, just to the southwest of downtown. Houston is kind of defined by 2 loops. The 610 is we call the inner loop, and the outer loop is the Sam Houston Tollway, and the medical center is within the inner loop. But Sugarland is over here. That's where the Sugarland Hospital is. Houston Methodist West is out I-10 in this direction. Willowbrook is up 290 in this direction, this part of town. Woodlands is north of Houston and up around the airport. Then what used to be San Jacinto Hospital, and now it's called Baytown, is over here in sort of to the northeast of downtown. And then finally, Houston Methodist Clear Lake is down I-45 south, down toward the Johnson Space Center, which I highly recommend if you ever visit Houston that you visit. By the way, has anybody ever been to the Texas Medical Center? Yeah. What?
I trained in Galveston.
Oh, did you? Yeah. So you're familiar with the area. Okay. So that's all for the shameless promotion. Now I'm going to start out with another kind of shameless trick, and that is I'm going to show you a video, and I'm doing it mainly because Tom Hanks is a lot more interesting than I am, and so you're a lot more likely to be, engaged in this if I show you the clip first. But we're not really going to talk about the meaning of it and how it relates to medical errors until later in the talk, but we'll come back to it. But let's look. Did anybody see the movie Sully? Yeah, several of you have. If you haven't, it's a movie about an airplane crash that occurred in 2009. It was a U.S. Airways flight out of LaGuardia in New York. And shortly after takeoff, it encountered a flock of birds. Airplanes usually can withstand bird strike, but this many ended up causing failure of both engines of the plane and unable to make it back to safely land at an airport without any power. Captain Sullivan ditched the plane in the Hudson River, and there were no casualties. Everyone survived. But of course, as with any airplane accident, it was investigated by the National Transportation Safety Board, and they had a hearing, and I want to show you a video clip from that hearing. If you haven't seen the movie, it was a great movie. And I'll just add to that, that they lost engine power at 2,800 feet, and single engine small private aircraft, they usually cruise at 5,000 feet. So he was about half the altitude that a single engine small craft would fly at. It's just astonishing that he was be able to bring it back in. But I want you just to put that in the back of your mind and remember that video, because we're going to talk about it a little bit later. What I'm going to do in this talk is I'm going to talk about three things. Number one, I'm going to talk about how often medical errors occur. And I'm not going to spend a lot of time on that because we all know that medical errors occur, right? You've seen them yourself. You may see them just about every day. We see mislabeled specimens. We see specimens that are contaminated. We see specimens that are drawn in the incorrect collection device. We see all of those things. So we know they occur, but I'll try to put some numbers on how often they occur, but I'm not going to belabor it because it's not really important how often they occur. It's more important, what do we do about it when they do occur? So the second part of the talk, I'll talk about what do you do, how do you investigate an error after it occurs? And we're going to sort of use as the model, and one of the reasons for this video, we're going to sort of use as the model investigations of airplane accidents, because there's been a lot of things written about investigating accidents that occur in aviation. And we're going to talk about two really, really good authors and what their thoughts are on the proper way to approach those investigations and the pitfalls to avoid when you do it. And then the last thing we'll do is we'll take a little break, and then we'll come back and we'll look at some actual true case histories that have been published on a website that I'll tell you about that involve medical errors. And we'll sort of brainstorm amongst ourselves as to what caused the error, what might have prevented it, and what do we learn from it. So there will be some feedback. We're not going to break into small groups, so you don't have to worry about that. We're going to do this all together. This is a quote that I heard in a leadership forum that was in California many years ago, and it really kind of struck me. It was a quote by this guy, Harvard, or Lawrence Henderson, a Harvard professor, and he said, "For the first time in human history, a random patient with a random disease consulting a doctor chosen at random stands a better than 50-50 chance of benefiting from the encounter." And that's what he called medicine's great divide. And I put, what date do you think he said this? Well, there's a clue, of course, because he died in 1942, so you know it was before then. But I won't, open it up for guesses. It was sometime in the 1920s. So it's only been in about the last century that visiting a doctor, you had a better than 50% chance of benefiting from your interaction with the medical care system. And I think that's really an astonishing thought, that throughout all of the rest of human history, it was like a crapshoot going to a doctor for help, because they were just as likely to harm you as they were to help you. So I think that this sort of highlights the fact that we take errors very seriously nowadays, because we have the means by which to determine what is the correct thing to do and what is not. Back 100 years ago, they probably wouldn't have even known. So it all got started with a report that came out that was authored by or is commissioned by the Institute of Medicine, which is one of the branches of the NIH. And it was called "To Err is Human, Building a Safer Health System." And that was written about a quarter of a century ago. And they examined 6 different features of medical errors. 1, how often do they occur? 2, how much do they cost? 3, what sort of outcomes occur as a result of medical errors? 4, what types of medical errors are made? 5, what causes these medical errors to happen? And they also gave some recommendations on how the medical care system, the healthcare system, can adapt and change its practices to reduce the frequency and the impact of these medical errors. Unfortunately, the report also had something in it that got the attention of the mass media and has been quoted over and over and over. And I'm going to delve into where that number actually came from and whether or not it's something that we can really place a lot of faith in. And that number is 100,000. You've heard it. There's up to 100,000 people every year in the US die from medical errors. I'm sure you've heard it in one talk or another, or seen it printed here or there. So we'll look at where that number actually came from. But first, I want to define one of the things that report did very nicely, I think, was to define what we mean when we say medical error. And if we just focus on the word error itself, it can have a number of meanings. It can mean you did something wrong. It could mean that you didn't do something that you should have done. It could mean that that you overlooked something that that you shouldn't have overlooked. It could mean several things. And they tried in this report to define exactly what was meant by an error. One thing that we talk a lot about in medicine are adverse events. This happens when you don't get the expected outcome, and the outcome that you get is worse than what you would have expected. And we call those adverse events. It's an injury caused by medical management rather than the underlying condition. So it's not something that somebody just went bad because their disease got worse. It's because an intervention was made and it didn't have the outcome. It had an adverse outcome, or an outcome that wasn't as beneficial as it should have been. An adverse event that is attributable to an error is called a preventable adverse event, because if you prevent the error, you prevent the adverse event. Negligent adverse events represent a subset of the preventable adverse events that satisfy a legal criteria for determining negligence. So we're not going to go into that, but that would be where you have done something that doesn't conform to standard practice of your specialty or of medical care, and that makes you liable for malpractice or some kind of liability settlement. An error, in contrast to an adverse event, an error is a failure of a planned action to be completed as intended. And that could be an error of execution. You intended to do this, but you didn't do it the way that it should have been done, or the use of a wrong plan to achieve an aim, an error of planning, like an incorrect diagnosis that is treated and the treatment doesn't help or maybe harms because the diagnosis was not what you expected. And about half, what the Institute of Medicine estimated was that about half of all preventable adverse events are considered negligent, are considered that someone really messed up. Now, errors of omission are the result of actions that are not taken. You know, you should have done this, but you didn't do it. An example that they give here, you forget to strap a patient down when you move them on a gurney and they fall off. That's an error of having forgotten to take an appropriate safety precaution. Errors of commission occur as the result of a wrong action that is taken, and that would be like administering the wrong medication or the right medication at the wrong dose. And we're going to focus a little bit on medication errors because they happen to be the most common. The examples of medical errors, and there's a lot of them, and I think that this is a pretty good list. There can be diagnostic errors where you simply misdiagnose the patient, equipment failure where maybe a ventilator malfunctions or something like that, maybe as a result of being programmed incorrectly. Infections, we know about that as microbiologists, right? That infections within infections that occur as a result of hospitalization are all too common. I often say that, if you're sick, the hospital is a horrible place to be because you're exposed to so many things that can make you worse. Transfusion-related injuries like taco or trolley, misinterpretation of medical orders where the medical order was given, but the person, the nurse usually who follows that medical order misinterprets what it was intended to do, and system failures. And we're going to dwell quite a bit on systems and how systems can fail because unfortunately passed away a couple of years ago, a guru in that area named Richard Cook, who I think has some fascinating insights on complex systems. And I think medical care is a prototypical complex system. So many parts that have to coordinate and move together in order for it to function. But system failures that compromise diagnostic or treatment processes. So let's go back to that IOM report and that 100,000 figure. Where did it come from? How did they know that 100,000 people die from medical errors? Well, they didn't, is the answer. They went to the literature. They tried to find any data in the literature that could help them estimate what the total number of deaths were. Well, it turns out, not surprisingly, there's not a whole lot of literature on this topic, mostly because hospitals are not really anxious to publish their errors, and especially when people die from those errors. So there were two studies that made a stab at this. One of them was done in New York, and basically they retrieved medical records from a sampling of patients, not all of them, of course, but a sampling of patients. They had them reviewed by medical professionals. I think they were probably physicians, although maybe some of them were nurses, and decide whether or not there was any error in the treatment of the patient. And then they determined whether the outcome was affected by that. Now, a lot of that's opinion. For one thing, there has to be a threshold above which you consider something an adverse event. If somebody, gets a little, hematoma at a site of drawing blood, that probably is not considered an adverse event. It's benign and it happens very commonly. But so they had to make that decision. Was it an adverse event or not? And number two, they had to make the decision, was it caused directly by a medical error? And those are two pretty subjective things to assess. And I think you've all been in the healthcare system long enough to know that you take any two doctors and try to get them to agree on something, it's often a futile effort. So I acknowledge the fact that they tried to make it objective. They did their best to make to get an objective assessment. The two, for example, had to agree on whether or not it was adverse and whether there was harm and whatnot. But I'm just making the point that I think in many respects it's an impossible task. So then once they decided that there were about 3%, 0.7%, well, let's say in the New York study, 2.9% occurrence of adverse events, that in about just under 3% of hospitalizations, the patient experiences some kind of harm or adverse event as a result of their treatment. 58% of those they determined were a result of some error that was made in how the patient was treated. Some adverse events you can't predict. I mean, you give somebody a drug they've never had before, they turn out to be allergic to that drug. That's an adverse event for sure, but there wasn't really any error that was made because there wasn't any indication that the patient might have been allergic to it. About 13.5% or so resulted in deaths. So then they take the combination of those three percentages, they put them together, and they apply that to how many patients are hospitalized in the United States in a year. And when they do the multiplication there, they come out with a figure 98,000. So I think as scientifically minded people, you can see that there's all kinds of things that might be wrong with that. Number one, you're just using a New York population to simulate the entire country. Number two, the subjective nature of some of the decisions that they made. The other study that they found was a healthcare system in Colorado and Utah, and they got similar numbers: 3.7% adverse events, 53% errors, but only 6.6% were fatal. Don't know why the difference, only half as many. So they came up using the same total number of hospitalizations in the US. They came up with an estimate that was 44,000. Well, right off the bat, you can say, how reliable are two estimates when they differ by a factor of 2? I mean, there was really no consistency between those. And I think in fairness, the report acknowledged that these estimates, have possibly a great deal of variation that are included in them. But of course, the media doesn't pay any attention to the caveats and to the fine print. They just said 100,000 people die a year in the US from medical errors. So I wanted to put that a little bit in perspective for you, that medical errors and the consequences of them are things that are really difficult to quantify. We know they occur. We know they're much more common than they should be and relatively common overall. But do we know exactly the number that happen and the number that result in deaths? No, I don't think we really do. Possibly it's even more than this. I don't know. But these estimates were very crude. And so when you see that number quoted, the Institute of Medicine estimates that as many as 100,000 people a year die in the US from medical errors, then, you can take it with a little bit of scientific salt. And this just kind of reviews what I have already told you about how they went about getting that data. Of course, you always have to estimate the cost, and the cost of adverse events, and that's all of them, whether they result in a death or not, is been estimated around $37 to $50 billion a year. About half of that is the healthcare cost, extended stays, additional treatment, all of those things that happen when the outcome is not as good as you wanted it to be. Preventable adverse events account for about 17 to 29 billion of that total, or somewhere about half of it. And that's what we mentioned in the previous slide, where we said about half of adverse events are considered preventable. Half of the cost is healthcare. Half of that total cost. The rest is things like lost income, household production, disabilities, things like that aren't direct medical costs, but are consequences of having an adverse event. It represents about 4% of adverse events, or the cost is about 4% of the total cost of medical care is due to these adverse events, and about 2% for errors. When you look at it in terms of the total healthcare costs, and that exceeds, somebody has pointed out, that exceeds the cost of treating HIV and AIDS. Okay, so then we'll look at some more specific and more current data. As I mentioned, the IOM report was from a quarter of a century ago. These are more contemporary data, I think, from within the last few years. And this was data that was compiled by a study commissioned by the Department of Health and Human Services and the Office of Inspector General as to what are the most common medical errors that occur. They estimated that about 25% of all Medicare patients, that's all they studied, experience some kind of adverse event. That's about 1 out of every 4, or a fourth of all patients. 12% had an adverse event, and 13% had what they called temporary harm events. I think I probably misspoke. I said 25% had adverse events. Now, only 12% actually had adverse events, but these temporary harm events were defined in a different way. It's the rate and number of patients who experienced temporary harm events are patients who had at least one temporary harm event and no adverse events. And I apologize, I forget exactly how they define the temporary harm events, but they distinguish it from adverse events in some way. And honestly, I don't recall that. But I think this just reinforces the fact that in medicine, when things don't come out how you expect them to, and you have a worse outcome than you wanted, this happens pretty frequently, at least probably in 25% of patients. And it's not benign because the patients actually are harmed in one way or the other. And this data was from 2018. Then they looked at what kinds of things are most common. And it's not surprising, I think, that medication errors are the most common type of medical error that causes an adverse event, because every patient that goes in a hospital gets some kind of medication. Maybe it's something they were already taking or something they're put on while they're in the hospital, but it's pretty common. So it's a ripe area for errors to occur because it's so common. I mean, virtually every patient has some potential to have a medication error. Errors in patient care are comprised about 29%, or of all 23%. 22% are harmed by some procedure like surgery. 11% by infection, as we mentioned before. Those hospital-acquired infections are relatively common. In the American Hospital Association list of medication errors, they compile a list that says these are the things that can go wrong with medication. You can have incomplete patient information. You can, perhaps not have an adequate assessment of renal function or something like that. You can have unavailable drug information or warnings that should have been passed on to the caregiver but aren't. Miscommunication of medication orders. The doctor orders one dose and it's misinterpreted as another. Confusion between drugs with similar names. Lack of appropriate drug labeling, and environmental conditions that distract healthcare providers. For example, you have a pharmacist who's trying to fill a prescription and they get distracted by something else and they lose track of where they were in that process. I think we can all identify with that, right? The most common medication errors are, number one, at about 14% are failure to adjust dosage in response to a change in liver or renal function. History of allergy that didn't get transmitted, wrong drug name, incorrect dosage calculation, and atypical. So these are relatively common errors that occur in a healthcare setting. And I think it's been known for some time that medication are probably the most likely errors to harm a patient. Thank goodness it's not lab work. So I just want to make a statement here that, and I think you'd have to agree with me, humans are notoriously bad at assessing risk and probabilities of bad things happening. And this is a comparison. Say your risk of dying from a medical error is about 1 in 1,000. We don't really know what it is, but I think based on the estimates, we can come around to something maybe around 1 in 1,000, which we would consider to be unacceptably high. Well, the risk of dying in a commercial airline accident is about 1 in 8 million. But I think that you wouldn't have to look very hard to find somebody on the street who is a lot more afraid of getting on an airplane than they are being admitted to a hospital. So you have to put, I think, things in perspective, that the risk of being harmed by medical error is not trivial by any means, but it's not 50% or 75% either. You know, it's still a relatively low probability. Okay, so now we'll go into the second phase. We'll talk about how do we determine what happened when we go back and we look at an accident that occurred, just like they were doing in the Sully video clip. They were looking back at the accident and saying, you know, what happened? It turns out, and I find this to be a fascinating and maybe very revealing statistic, is that across virtually all types of industries, when you look at accidents that occur in an industrial setting and what was the cause of that accident, pretty consistently across all industries, about 20% are attributed to systems failure and about 80% are attributed to human error. And you might say, well, you know, that probably makes sense. Humans are fallible. You know, we're not perfect. We make mistakes. And that's the case in any industry. But it just strikes me as a little odd that, you know, this applies to, you know, a landscaping company, and it applies to the airline industry. You know, two that are hugely different in terms of the technology that is put into making the system safe and keeping errors from causing catastrophic accidents. And so when you think about why this would be, why is this percentage so consistent? Why do we almost always assume something is caused by human error? Then I think you have to look at what our basic instincts are when we observe the behavior of others and why we might be biased in favor of human error as a cause of accidents. So the first person that I mentioned is a guy named Sidney Dekker. He's an airline captain, and he is from Sweden, I believe. Might be Denmark, but he wrote a book about 20 years ago called The Field Guide to Human Error Investigations. And this was based on his experience as an investigator for aviation accidents. You know, every aviation, not only in the US, but in the world really, gets very intensely investigated. There's a European Commission that does this. In the US, it's the National Transportation Safety Board. And he became sort of a guru on these investigation teams because he had not necessarily a unique, but a very rational and logical approach to trying to figure out what actually happened. And he came up with a number of pitfalls in trying to investigate an accident. And I want to go through those. And as I do, you can think back on that video that I showed you of Sully and him testifying before and the points that he was making, how he was being judged and how he refuted that judgment. When you talk about an accident investigation and maybe some human error was considered important in how that accident occurred, you can view the human error as either the fundamental cause of the accident, or it's possible that the human error is a symptom of a failure of the system in which the human was operating. Some systems, we call it, what do they call it? Set you up to fail. They predispose you to failure because they have points in it that might mislead you into thinking the incorrect action is actually the correct action to take. There's a couple of reasons that we tend to blame humans when accidents occur. One of them, Dekker points out, is called the bad apple theory. And it is based on the assumption that complex systems must be inherently safe. They're complex. They were designed by many people. They've been they've been tested, they've been analyzed extensively, so they must be safe. And if anything goes wrong with that complex system, it must be due to some human intervention that caused an error to occur. That human intervention subverts the inherent safety of complex systems. And the second error that we make is that in our reaction to failure, our tendency is to say, well, if it had a bad outcome, then it was a bad decision. If it had a good outcome, then it was a good decision. And you're judging the quality and the appropriateness of the decision based on the outcome. And the fact is, and we'll explore this a little more in a minute, but the fact is the person who was making the decision didn't know what the outcome was going to be. If they did, they probably would have made the right decision. And reaction to failure is always retrospective. It's always proximal, it's counterfactual, and it's judgmental. And I'm going to look at each one of those descriptors, because every single one of them, with the possible exception of one, was illustrated in that video clip that we looked at. The bad apple theory is sort of based on a lot of misconceptions. One of them is the illusion of success, because bad procedures often often produce good results. It doesn't have to be a perfect procedure to produce a good result. It can be a bad procedure that just coincidentally happens to produce a good result. And one prime and familiar example I can think of that is the Challenger disaster in 1988. There was a design flaw in the shuttle. It had been a design flaw since the shuttle was first launched. It had been a design flaw for, 12 or 13 years of shuttle launches. And so there was this temptation of the engineers to say, well, we've never had any accidents, so the system must be safe. Well, the system wasn't safe, and eventually it shows that. But success, because we don't see a bad event for a long time, we think, well, that must be evidence that the system is safe, and it may not be right. That failure is an aberration, that the default for the system is going to be that it's safe, and that if it fails, then that's an outlier. That's something that is an aberration and must have some fundamental cause other than the system itself. And finally, and I think you can all appreciate this, there's an economical answer to it. If you have a system and the system fails, and it was because someone operating within that system, maybe because the system was poorly designed and didn't give the operator the correct options or the useful options, then it's easier to change the human behavior than it is to redesign the system. So we have a tendency to say, well, it was human error. Why don't we do something just to change the way the humans do it, rather than changing the system so it reduces the opportunities or reduces the probability that a human is going to make an error in that system. Okay, so we'll talk about those four things that Decker talks about when you analyze an accident. These are the mistakes that you're likely to make. And the first is that your analysis is always retrospective. You're looking back on something that happened in the past. And I like to think of this in terms of the old saying, hindsight is 20/20. Because when you look at something in hindsight, you know exactly all the features of it and everything that happened and all. Well, I would suggest that hindsight's not 20/20. Foresight is 20/20, because when you're looking at something as it happens, you can see actually how the event occurred. You're right in the middle of the event. So the guy on the left there, he's the guy that's experiencing the event. He's seeing it exactly as it occurred. The guy on the right, he's investigating the event. He's looking back at it through everything that has already happened since the event occurred. And so his view of the event is clouded by the fact that he knows what happened. He knows what all the consequences were. So he can't possibly see it the same way that the guy on the left saw it. So one problem with analyzing, with investigating accidents, is that they're always retrospective. And you have to keep in mind that looking at something retrospectively, you don't see it the same way that the person who was involved in the accident saw it at the time. Second is proximal. We have a tendency to think that if we want to investigate something, we have to investigate where it occurred. Let's say we have a mislabeled specimen. So let's go to where the mislabel occurred and who mislabeled it, and you know, what were they doing at the time, and all of those factors that are proximal to where the error occurred. But what Decker points out is that you have a sharp end, and that's where the accident occurs, and a blunt end to every accident. The blunt end is all of the systems and procedures that influence the sharp end. And we can look at that graphically like this. Here you have that timeline again, and the sharp end is where that little starburst is right there. The blunt end, I mean, you can focus your investigation on the sharp end, and that's what our temptation is to do as human investigators. But there's also the blunt end, which are all of the infrastructure things like the institution, the systems, the procedure, organizational policies, things like that, that influence the behavior at the sharp end and can be responsible for a misjudgment and a accident that occurs. Here's the one I like the best, though, counterfactuals. And this is the one that I think was best illustrated by the video that we looked. Counterfactuals are looking back at something and saying, but if they would have done this instead of that, then they would have avoided the accident. If Captain Sully would have immediately turned his plane back toward Teterboro and headed toward that runway like they did in the simulator after 17 tries, then he would have been able to land the plane. So counterfactuals suppose that if you had acted differently, then you would have had a different outcome. And although we are always tempted to do that, say, well, you know, what it should have done is this. But the truth is, you're looking at it through a different view than the person who is doing it. And so to them, the action that you can propose as a counterfactual may have looked either, you know, off the table, or may have looked like it would obviously be the wrong action, or maybe like in the case of the airplane, they just wouldn't have had time to consider that as an option. You know, when you've got plenty of time to sit down and do the investigation and think it through and go into a simulator and give it a try, then yeah, you can come up with a way that he could have gotten out of it. But was it reasonable to believe that he would have been able to do that when he was in the cockpit experiencing an emergency like no one had ever experienced in a commercial airliner before? No, it just wasn't reasonable at all. And that's why I like that clip so much, because it illustrates there's nothing. I know you've done it too. You've looked at something where somebody, you know, some bad outcome had occurred, and you said, you know, what they really should have done is this, because then this wouldn't have happened, and then this wouldn't have happened. And the truth is, counterfactuals pose alternative scenarios, but they're rarely useful in determining what the cause of an accident was, because trying to suggest that somebody didn't make a decision that you have had all the time in the world to consider and evaluate and try just is not fair. And finally, assigning blame is judgmental. I think maybe I put this on the next slide, but this I think is a very, very important point. When you investigate an accident, and even when you're not investigating it, maybe you're just looking back on it or hearing about it, you always know more than the person who was involved in. And it is never fair. It's impossible to judge somebody fairly when you know more than they did. And so when you look back on someone's actions, it's easy to say, well, you know, that was just the wrong thing to do. You did the wrong thing there. But you have to be able to put yourself in their position and look at what information they had available to them at the time and say, did they make a reasonable decision, or was it, I mean, obviously it wasn't maleficent. I mean, they weren't malevolent. They weren't trying to make things fail, but you still can't judge them fairly when you're looking back and you know what the outcome of their action was. If they knew what the outcome was, sure, they would have chosen a different path, but they didn't know what the outcome was. So, and I think that that was illustrated in that video clip, because they didn't know. Number one, they were completely unprepared for losing both engines at 2,800 feet. It never happened before. They don't train for that. They do train for water landings, but whether the best thing to do is to try to restart the engine, whether the best thing to do is immediately turn back, whether the best thing to do is to contact the tower and tell them that you have an emergency and you need to turn back and to give you vectors and all that. Well, they did that, but there's a principle in aviation. I only know this because my son is training to be an airline pilot. There's a principle in aviation called aviate, navigate, communicate. And whenever you have an emergency in flight, the very first thing you do is you concentrate on flying the plane and making sure the plane is stable. Then you navigate, you figure out where you are, and then you communicate. So even asking the tower for, where can I land this plane is third on the list of a pilot's priorities when they have an emergency. So obviously, as it was pointed out in that, they didn't give them any time for that decision process at all. So they decided to give them 35 seconds. I don't recall how, I think as I recall in the movie, when they put in that 35 seconds of decision time, then nobody was able to land the plane safely. Okay, so these are the lessons for investigators of accidents. Number one, there is no primary cause, and we'll talk about this a little bit more. Our temptation is to say, well, let's drill down and let's find out what caused it, and we'll fix that, and then it won't happen again. Well, the trouble is, in complex systems, especially like medical care, there's almost never a single cause. It's always a combination. Errors in complex systems are nearly always multifocal. And the definition of what is a human error is elusive, because I think, as we've sort of seen, just because somebody takes the wrong action doesn't necessarily mean it's an error. It may have seemed like the perfectly logical and appropriate action to take under those circumstances. Lisa Belkin is an author. She's written a number of books, but this was an article that she wrote for the New York Times, and I think it is especially pertinent to what we're talking about, and we're going to explore this just a little bit more in a few minutes. In an article that she wrote called "How Can We Save the Next Victim?" I read this article a long time ago, and I think that it was based on a true story, a patient that had been harmed, by a very unfortunate combination of medical errors and had a horrible outcome. And she wrote an article on it called "How Can We Save the Next Victim?" And she said, it is virtually impossible for one mistake to kill a patient in the highly mechanized and backstopped world of a modern hospital. A cascade of unthinkable things must happen, meaning catastrophic errors are rarely a failure of a single person, and almost always a failure of a system. And that's what I'm going to try to convince you, that looking for one single cause is probably not an effective or even rational kind of approach. And there's some support for that too that we'll see in just a minute. You've probably heard this called the Swiss cheese model. In any complex system, you have multiple layers that have to function in order to produce a certain outcome. Each one of those layers has certain failure modes associated with it. Failure in one probably is not going to cause a failure of the entire system. It has to be that unusual circumstance where the failures sort of line up like holes in Swiss cheese, and the action makes it all the way through to cause an adverse event at the very end. Most of them, like these, this one is stopped here, this one is stopped here, this one is stopped here, but this one gets all the way through. So we'll talk for just a couple of minutes about something called failure mode and effects analysis. Looks like FEMA, the Federal Emergency Management Association, but you just transpose a couple letters. But it's an engineering concept, and it's an engineering concept that is designed to assess the safety of assess and optimize the safety of a system against failures. It's based on something that sounds like it came out of Murphy's laws, which is everything will eventually fail. That you have to start with the assumption that there is absolutely no fail-safe process, that everything can fail in some way. Humans frequently make errors. I think anybody would agree with that. We're human. We're not perfect. We try as hard as we can not to make errors, but we're not robots. We're not perfect. The cause of a failure is often beyond the control of an operator, and I think that's an interesting point. But I want to tell you how FMEA works. It's basically 10 steps. You review the process, you analyze intensively the process that failed, look at each component of that process, how it works, who it involves, etc. You then brainstorm eventual failure modes. You say, let's say, for example, labeling a blood specimen. What are the ways that there can be a failure in the labeling of that specimen? Well, you can have not enough training of the people doing it, that they don't pay enough attention. You can have errors in the barcode printing. You can have, the workplace being so busy and chaotic that they just can't concentrate well enough to be able to keep track. I mean, or they didn't label it at the bedside. Oh, so you speculate. What are the ways that this particular process can fail? Then to each failure mode, you assign a severity rating. If they make this error, what is the consequence? How severe is the consequence going to be? For example, say it's a computer sort of thing. If the computer room floods and it shuts down our computer system, how severe is that going to be? I think we'd agree, pretty severe, right? All of you that have been through a computer downtime. So you assign how severe is the consequence going to be with any given failure mode. Then you assign an occurrence rating. What's the probability that that failure mode might occur? What's the probability that our computer room is going to flood? Well, you can look at weather maps and weather histories and things like that, but maybe it's very, very unlikely that you would get enough rain to flood your computer room. So the occurrence rating of that might be very low, even though the severity rating is very high. And then you assign something else, which I find kind of interesting. You assess a detection rating. How likely is it that we're going to detect this error if it does occur? There are some subtle errors, and I think many of you have had some experience with this, where particularly in the computer system, you can have an error occurring and nobody knows it's occurred because it doesn't cause any obvious change in the function of the computer system. So it goes on for a while without anybody detecting it, and the damage that it can cause increases over time. So you take those three things and you calculate a risk priority number. It's either the sum of the three numbers, each one is 1 to 10 or something like that, and you prioritize the failure modes based on the risk priority number, and you would of course prioritize severity. You want to minimize the risk of the most things that will cause the most severe consequences. Then you take action to reduce or eliminate the high risk failure modes, and then you go back and you recalculate the RPN. So this is an engineering process to try and create systems that are least likely to fail, or that are most backstopped against failure. The Institute of Medicine had a number of recommendations after their report for how we can improve the system, and I'll run through those quickly. Establish a national focus on medical errors, which I think they were successful in doing. Identify and learn from medical errors through mandatory reporting, and I think they did implement a system of mandatory reporting of medical errors that occur, at least the most serious ones. Raise standards and expectations and implement safe practices. And I'm not going to read through all this. It's kind of a history of the Agency for Healthcare Research and Quality, or AHRQ. I put it up because they had a number of recommendations we're going to go through really quickly, but it's also where I got the case studies that we're going to talk about later on. They published on their website. And honestly, since they were defunded in 2018, I don't even know whether that website exists anymore. I should have checked, but I didn't. And that's where those case reports came from. They published all of these case reports, and I looked at case reports specifically that involved laboratory results. And that's where I didn't make them up. They were actually true incidents that occurred, and they were reported on this site. The AHRQ had a top 5 recommendations, the first being survey staff in individual units and throughout the hospital to improve a culture of patient safety, limit shifts to more than 24 hours. They did focus a lot on this culture within medical education, particularly postgraduate medical education, where residents, work 24, 30, 48-hour shifts, as sort of a badge of honor to, or kind of an initiation ritual for residents. And they recognized, as many studies have demonstrated, that this increases risk. You just simply cannot function optimally or even adequately or safely when you're exhausted. So that was their second of their top 5 recommendations, and the third also had to do with duty hours for residents. So I think we are, and Yvette, you can confirm this. I mean, residents now are very strictly restricted as to how many hours they can work without. And that was basically because of this report. Adopt interventions to reduce the incidence of ventilator-associated pneumonia. And part of that, I think we learned this during the COVID epidemic too, is that people on a ventilator, if you put them on their in the recumbent position, isn't that face down recumbent? Yeah, then they have better outcomes. They're less likely to develop infections. And count surgical instruments. I mean, 1,500 times a year in the US, patients undergo surgery and some sort of surgical instrument is left inside them. And it's just a thing as simple as count them. Count them when the surgery is over to make sure that you retrieve them all. And the AHRQ also had recommendations for patients, as asking questions, bring a list of all the medications, get the results of any test or lab procedure. I think we're required to make those available to patients. Now, talk to your doctor about which hospital is best for you. Maybe the one you're in doesn't really specialize in the disease that you have, and make sure you understand what will happen if you need surgery. And these were, I just wanted to point out, the Joint Commission also has their set of patient safety goals. So I won't go through these all. I think probably all of them make sense to you, but I put it up mostly to point out that this focus that the Institute of Medicine recommended, this national focus on patient safety, got the message across, because the AHRQ came out with their set of recommendations. The Joint Commission came out with their set of recommendations. So, and the JCO had 12 different recommendations that, touch on virtually all aspects of healthcare. Finally, before we take a short break, I'm going to talk a little bit about Richard Cook. Like I say, unfortunately, he passed away a couple of years ago. He was at University of Chicago, and his background was that he was an engineer. I think it was either chemical engineering or systems engineering or something like that. But then he went to medical school and he became an anesthesiologist. And the thing that fascinated him was, in complex systems like medical care, what are the ways that it can fail? What causes failure in the system, and how do we minimize the opportunities for failure? And he said, recognizing hazard and successfully manipulating system operations to remain inside the tolerable performance boundaries requires intimate contact with failure. And I was really confused by that quote for the longest time, because I said, what does he mean by intimate contact with failure? And as I read more of his book, How Complex Systems Fail, it became obvious to me that what he's getting at here is you have to know how the things can fail in order to be able to create a safer system. And I'll show you why I think that that's the fundamental point he was getting at. These are some of the points that he makes in his book, and I've got about 4 slides of these, and I've highlighted the one on each slide in red that I think is probably the most salient to healthcare systems. Catastrophe is always around the corner. That's sort of the same as every system is going to fail. And it sounds like a Murphy's Law. But the important one here, I think, is post-accident attribution to a root cause is fundamentally wrong. And I've already made this point that one failure doesn't usually cause a system, doesn't usually cause a bad outcome. It usually requires multiple failures. And that's why Cook said he understands that concept. And he said, attributing it to a root cause is fundamentally wrong. And, yet we do it, don't we? You've all heard of root cause analysis. I think it's even in the CAP accreditation guidelines that you need to, does your QA program include a root cause analysis? When the state of Florida came out with the requirement that you have 2 hours of medical error education, they included root cause analysis among the objectives within that. But I think it's misguided in a way. It's not necessarily harmful, but it's misguided in that it leads you to thinking that one thing is going to solve this, when in fact it probably was multiple failures, and you have to approach rectifying it in that way. The second one that I thought was really interesting, along the same line, catastrophe requires multiple failures. Single point failures are not enough. And that was exactly the point that Lisa Belkin made in her essay or in her article in the New York Times, that it's almost impossible for a single failure to bring a system down. It usually requires several. Change introduces new forms of failure. And this one I think I like because it's non-intuitive. So I can actually tell you something maybe that you didn't know before. When you operate in a complex system, and I think those of you that are managers of laboratories will appreciate this, that, I've always observed that that laboratory people are very clever, and they want things to operate as efficiently as possible. They want to get their work done quickly. They want everything to be done correctly. And so on the fly, they will develop workarounds if they perceive that one of the components of the process doesn't work as optimally as it should, that maybe it slows it down a little bit. So they will create these workarounds, and it's not unique to the laboratory. It happens all over the hospital, where there's some process that doesn't seem to be working quite as well as it should. So the staff will create little workarounds that will try to improve the process. Well, the fact is that every time you create one of those, you create another failure mode. And it's an undocumented failure mode. It's a failure mode that is not referenced anywhere in any procedure manual or policy manual. And we do these things all the time. So we are continually changing our processes. And when we do that, Cook points out, you are creating new failure modes for the system. And that's something that you have to appreciate. Okay, so why don't we take a little break, take about 10 minutes for nature, or get yourself somewhere to eat or something like that. And then we'll do a few case histories, okay? When we come back at about, we'll say 10 minutes, okay? It's hard to sit for 2 hours, unless it's a really good movie. that we can, let's get started so we can get you out of here at a semi-reasonable hour. As I promised, the last part of this talk is going to be some cases. These are real cases. They weren't at my hospital, but they were on that AHRQ website, and they involve laboratory work. So I hope it'll be relevant to you. But what we'll do is we'll go through the case history. We'll ask some questions. You know, what do you think went wrong here? You know, what are the potential failure modes? So as we read these case histories, be thinking about, if I were investigating this, what kinds of things would I focus on that might have contributed to the poor outcome or the adverse event that occurred. And then we'll just discuss it a little bit. I've got 3 of these, and then depending on how much time we have left, I'm only going to go about 40 more minutes, 30 or 40. And if we have time, then I'll go through a real life example from my experience. But if we skip that, it's not going to bother me because it's kind of painful to go through it over and over. So the first one, this is a 71-year-old woman with congestive heart failure who was admitted to the hospital. Her medical history was significant for dialysis-dependent ESRD, coronary artery disease, and she did not have a diagnosis of diabetes. She was in the step-down unit the evening of admission. The patient had a routine phlebotomy sample drawn, and the blood sugar was 674. And in a non-diabetic patient, that would be pretty unusual, wouldn't it? At 11:30 p.m., the nurse notified the covering intern, who telephone ordered 10 units of insulin to be given sub-Q. At 1:10, this is about not quite 2 hours later, a fingerstick glucose was 50. The intern verbally ordered 1 amp of D50 to be given IV to try and raise her blood sugar, because as you probably know, I mean, a low blood sugar is a lot greater risk than a high blood sugar. High, of course, has a risk, but low blood sugar has an immediate life-threatening risk. At 3 a.m., a phlebotomized specimen revealed a glucose of 19. The intern verbally ordered another amp of D550 IV, as well as a D10 drip. I guess that's dextrose 10%. At 5:27 a.m., this is about what we're talking 11:30 to 5, yeah, about 6 hours later. A fingerstick glucose was 99. At 11 a.m., about another 6 hours later, a phlebotomy sample glucose was 351. Another covering intern was notified, and 8 units of insulin were ordered to be given subcutaneously. At 3:40, the patient was unresponsive, and a fingerstick glucose was 13. 2 amps of D550 were verbally ordered, and a follow-up fingersticks were in the normal range. Okay, you probably are. This is just a summary of all the lab results, but clearly, you know, she was having lab results that were inconsistent. They were doing therapeutic interventions based on those lab results, and so it was a series of errors that were made in this case. So, what do you think's going on? What's causing this? Sorry?
Erroneous result somewhere.
Yeah, yeah, but in some respects, consistent. You have the finger sticks were always, you know, relative normal or low. The ones drawn for the lab were, except for the 3 a.m. specimen, were all very, very high. Yeah, yeah. And we've seen this. You've seen it probably too. The nurses, I just don't think they get the kind of training that alerts them immediately to things like this. But you know, they're just draw a sample out of an indwelling IV, and the samples were being drawn from an IV. I think I've summarized this on the next one. It was discovered that many of the phlebotomy specimens had been drawn above an IV line infusing dextrose. The step-down nurse was re-educated regarding blood draws in relation to lines, despite multiple episodes of hypoglycemia. The good news is the patient survived this and didn't have any lasting harm, which is almost a miracle. So let's think about this a little bit. What were the systems and processes that were involved in this overall system failure? Well, one we've already brought up is nursing education. The nurse just didn't understand that you don't draw a sample for glucose below IV that is administering glucose. You don't do that. So that was one feature of the system. Were there others?
I'm not sure if it's a process, but it seems like the physician was making a decision without actually seeing the patient in every case. It was just based on something that somebody had told them.
And I would say in addition to that, he was making a decision, not only had he not seen the patient, but he probably hadn't reviewed the lab results either. Because the second time that they ordered insulin, they had already had this incident where he'd given insulin and the glucose dropped way below. So that should have alerted them to the fact that, insulin may not be the thing we want here. So you're right. I think it hadn't fully assessed the patient. They were just reacting based on what the glucose was. Did the doctor even know that the patient was not diabetic? So that's definitely a point of failure. Any others? I question here a little bit because it wasn't in the history, and that may mean that it didn't get done, or it may mean that it did get done, but it just didn't get put in this history because the people who did this history probably weren't lab people. But weren't these critical results called? These are both critically low and critically high. There's no mention of calling and giving the critical results. Most places, I think here and certainly at Methodist, we do have a policy where we'll report a critical to a nurse if they're taking care of the patient. But with some critical results, you really ought to talk to the doctor and say, we don't really know what's going on here with this going up and down. So the lab, I think, had an opportunity to point out to them that these results were really inconsistent. Number one, I don't think you would reduce your glucose that drastically, that quickly, even if you administered insulin. So I think there were some communication problems. Probably the physician didn't really have complete information, and that's on them. They should have asked for that information. And yes, sir.
For these finger sticks, a glucometer finger stick?
Yeah.
Where they have laboratory?
I'm sure it was glucometer, but you think maybe, because our lab, I don't think, other than on babies, we wouldn't get any finger stick specimens in the main lab, I don't think. Not that I can think of. They used to collect them in microcontainers that we would do for the neonates, but the one at my hospital, we don't do that much pediatrics. So. They do for point of care, yeah. And that was the thing. The finger sticks were all reasonable. But, giving somebody 10 units of, I just also sort of question the prudence of the therapy, giving 10 units of insulin based on a single glucose result. That's treating it like it's an emergency, and it seems like it would have been more prudent to give like 1 unit of insulin and see whether the glucose came down. Like I say, hyperglycemia is not a medical emergency. It can become a medical emergency over time if you become ketoacidotic, but anyway, okay. So the analysis, I think, includes nurse training issues, laboratory intervention. Should the laboratory have, and maybe the laboratory didn't even know about the point of care results.
They'll report to the doctor what the result was. They'll write it down, but it takes time before it gets into the lab system.
Yeah.
Where someone else could review it.
If it gets in there at all.
When you're talking to the nurse, you'll get the result, but.
Yeah. Yeah, and like I say, if it gets in the record at all, I know there was a time when interfaces for point of care equipment were really rare. But, and I don't know what the date of this was, but, it could have been transcribed and the lab didn't even know about the point of care results.
Basically, the whole thing of with your pharmacy department have some sort of check the fact that they're ordering this going to the drug, that the PharmD there could be some sort of system check put in
Yeah.
place where you can.
I don't know how, I mean, not being a clinician, I don't know how prudent 10 units of insulin are, how often that occurs. But yeah, possibly the pharmacy should have been alerted or been alerted by the fact that this huge dose of insulin had been ordered on a patient, and they may want to go in and verify what the glucose was before they issue that. Yeah. Mhm.
I think here, I'm not sure if it's still the case, but I know that we used to have the finger stick confirmed when it was either too low or high.
Mhm.
That could be another good safety.
Yeah, I think what we would, and we advise them if they have a really high or really low finger stick to verify it with a lab draw. But in this case, it would have been, you still have to do the lab draw correctly. So yeah. So I put coverage issues, and I think what I'm referring to here is medical coverage. I mean, does the resident that was called and gave the order, do they really even know the patient, or are they just covering that service and reacting to a single laboratory value? But we stress all the time to our clinical colleagues that you can't take a laboratory result, no matter what it is, in isolation. I mean, the mantra that I got when I was training at UVA was treat the patient, not the lab result. And I think clinicians tend to, and I hate to put it this way, but I think it's a little lazy just to look at the lab result and say, okay, well, let's do this. That's like looking at your speedometer and deciding how to drive a car. I mean, there's other things that are part of it. Okay. All right. Any other comments on this case? All right, let's go to our second case report. We've got a 41-year-old woman who came to the ED with mental status changes. She had been diagnosed with a urinary tract infection outside of the hospital and started on oral ciprofloxacin 4 days earlier. She had fever, nausea, and vomiting in the days preceding presentation. She did not have a headache, focal weakness, or numbness. Past medical history was otherwise unremarkable. So we got a history of a UTI and on ciprofloxacin, but that's pretty much it as far as any significant. But she does have mental status changes. On physical exam, she was afebrile. She had sinus tachycardia at 123, otherwise normal vital signs, able to follow most commands, but she was alert but oriented to person in place only. I think the other component is time, right? So she knew who she was and where she was, but she didn't know what date it was, or I think it's, you ask them what year it is. Able to, let's see, a neurologic examination was otherwise non-focal, meaning just, generalized. There were no signs of meningeal irritation. So let's go on. About 40 minutes after she arrived, initial laboratory results were returned and had a white blood cell count of 12.7, which is elevated, right? 89% granulocytes. She had a hematocrit of 20.2, which is pretty low, and I didn't get a hemoglobin, but that would pretty much correspond to a hemoglobin that would prompt you probably to consider transfusion. A glucose of 204, BUN 36, which is elevated, serum creatinine 1.2 also elevated. Urinalysis showed moderate blood in the urine. Platelet count was pending at that time. They hadn't gotten the platelets back yet. 60 minutes after arrival, so this was like 20 minutes later, the patient was admitted to internal medicine service with a diagnosis of anemia and hematuria in the setting of a urinary tract infection. The medicine team completed the admission paperwork with plans to administer empiric broad-spectrum antimicrobial agents and packed red blood cells, so that she was going to get a transfusion for severe anemia. The outgoing ED physician had just completed the shift and signed the patient out to the oncoming colleague as admitted, with care already transferred to the internal medicine source. So we got a lot of things going on here, right? You know, she was transferred to internal medicine. She's got to be signed out by the ED. Internal medicine has to accept, has to get her admitted, and they've already have a plan for transfusing and putting her on broad spectrum antibiotics. So do you have any comments on the kind of care that this woman received? Did everything seem appropriate up to this point? Anything sort of stick out that might be a problem? Yeah, which one? And the platelet count. They had not gotten the platelet count back yet when she was transferred. Yes, sir.
The white count instead of 12,000, that's not that elevated
No, no, it's not.
for a UTI.
Mhm. You would know better than me on that. All of my, you know, most of my cases and comments have to do with chemistry, and I apologize for that, but I'm a chemist. I'm not a microbiologist. But I think it's a good point. You know, was it really consistent with a UTI that you would want to treat with, you know, with a lot of antibiotics? Good point. So what were failure points that you saw in this process?
The doctor transfer and the internal medicine transfer.
Yeah. I've always thought that, I mean, that's probably the riskiest process, because you have to transfer information from one to another. And, you know, sometimes that's verbal transfer, sometimes it's, you know, written things like that. And just to me, that's ripe for failure, because you probably know, as having practiced in a clinical lab, communication failures are some of the most persistent, because
Seems like something critical like that, that maybe the clinician should have followed through.
yeah.
The internal medicine transfer was completed.
Mhm. You know, and interestingly, you should bring that up about communication. Is it struck me for a long time, since, you know, before 1990 or so, email was kind of non-existent. You just never used email. You wanted to talk to somebody, you called them on the phone, or you went down to their office and you talked to them. But after email, I'd guess probably what, 90% or more of communications with your colleagues is by email. And you lose a lot of the communication when you write, when all you do is write it, and you don't have the inflections in the voice, the urgency, or, you know, those subtle little things in spoken word that convey meaning, not because it's in what you say, but it's in how you say it. And you can't do that. I mean, of course, you could put all caps, or maybe put something in italics to mean that it's emphasized. But to me, it creates more failure points when you communicate by email, because it's easy. You write something and you know exactly what you mean. Somebody else reads it and they interpret it completely different. You've all had that happen to you with, you know, I'm sure, with things that you've written. Okay. All right, continuing, 4 hours after arrival, the laboratory called the emergency department to report a critical lab result, which was a critically low platelet, 4,000. The critical result was received by the ED unit secretary. You see something wrong here already, don't you? It was ordered by the ED, so it's called to the ED, but the patient wasn't in the ED anymore. The patient was on the floor. The critical result was received by the secretary. It's unclear who this information was passed to, but neither the ED attending or the internal medicine service was made aware of this laboratory result. 16 hours after the patient presented to the ED, the internist noted the abnormal finding when checking the morning laboratory data. So this was 16 hours after they had a critical result. They didn't even notice it for 16 hours, much less take action on it. A critical result is supposed to, by definition, at least CAP's definition, and I think most responsible laboratorians, is a laboratory result that needs immediate attention and intervention with risk of life otherwise. So, where the patient required transfer to the she made a tentative diagnosis of TTP, transferred the patient to the ICU because of deterioration. The patient was eventually intubated. Hematology consultation was obtained to initiate an emergent plasma exchange for treatment of TTP. Despite these, the patient continued to deteriorate and died on the following day. So this sort of went downhill, didn't it? I mean, they thought they had a patient who was stable and they could transfer to internal medicine, and medicine was focusing on what? A UTI, and didn't even get informed of the low platelet count until probably, it doesn't say exactly how, I assume that she probably bled out or, died from internal bleeding.
Mental status? Because, I mean, I'm thinking if someone comes in even with a slightly altered mental status, that there has to be some sort of continual follow-up of how is that, is that progressing? Is it deteriorating? Is it getting better? I mean,
I think that's a great point, because the differential for altered mental status is this long. I mean, it could be drug related, it could be glycemia related, all sorts of things. Yeah, absolutely. Yeah, and it just seemed, I think you make a good point, because did internal medicine really consider that as something that required, evaluation? And altered mental status can be relatively benign, but it can also be very serious. Okay. So what were the systems and processes? We could go on probably for 20 minutes on this, but just give me your big ones. What were the processes that were involved in this?
12-hour period. Get the results.
Yeah, the system for how the laboratory reports results in a timely fashion. Why were the platelets held up? Maybe they had a bad specimen, they had platelet clumping or something, had to get a new specimen, I don't know. But I think a big one, of course, is transfer of the patient from one service to another, the ED. And of course, that happens every day. Any patient that goes to the ED and gets admitted, they get transferred from the ED to another service. The means for reporting critical results, the lab called it to the ED. Did they confirm that the patient was still in the ED, or that they were giving the result to the person who was taking care of the patient? They said they gave it to a unit secretary, and that, is problematic a bit.
Well, I mean, actually, it's interesting because that is a big problem that we actually have now. Because it's not so much an issue necessarily for chemistry, because they could still actually be in the ED to get the result.
Uh-huh.
For a lot of our stuff, if they're not.
Yeah, right.
And so the ED won't take it. Granted, they probably should, because they're not there,
Mhm.
right? But they don't know where the person went, so it's like they don't even know that he got moved to the internal
Mhm.
medicine service and he's on whatever floor now, right?
Yeah.
He or she. And, so it's like we're stuck with these results that nobody wants to take. And if they've been discharged, it's even worse.
Yeah, agreed. Because, I mean, we as a laboratory are obligated to report a critical to somebody that can do something about it. And if you don't even know where the patient is, then, who do you know how to call? And yeah, I think every laboratory faces that with outpatients. And, after hours outpatients, and trying to find somebody who knows enough about the patient, or who is willing to take the result and take responsibility for getting in touch with the patient and doing whatever they need to do.
because it said that basically the ED attending was like, he closed it, he was done.
Yeah.
And then, in my experience, there's usually a period of time where basically you belong to no one, because until the next service comes and picks you up,
Mhm.
it's like if someone calls in, there is no one to report to because you belong to no one. You are in limbo at that point.
Yeah, huge failure point. And what I, yeah.
On to so-and-so services.
Mhm. And if they, and if they have the habit of a unit secretary taking critical results, then that unit secretary needs to know what to do with them. And it sounded like there wasn't even any record that she had reported it to anybody else. So, and you can't expect someone with no medical training to understand the significance of a critical result. That, oh, okay, it's just a lab result. We get lab results all the time.
It's like a system error, though, considering that we are all on electronic medical records and it's within the same institution,
Mhm.
it seems like that the EMR would do the chain of custody within the system, that once a new provider or clinician
Yeah.
takes over for that patient, that those results should transfer over.
Mhm.
I don't understand the point of it being in a computer if the computers aren't working for us.
Preach it, brother.
Right?
Well, here's, just as a quick aside,
Yeah.
here's my beef with the electronic medical record. It was put into place right after 2010 or so as part of that huge budget reconciliation act that, was, I forget what the name of it was, but it was during the Obama administration. It was designed to stimulate the economy. The stimulus bill was what it was called. And so part of that was hospitals had to digitize their medical records. So they got all this money to do it, and they did it. And Shan's UF Health did it, and all the other, we went to Epic. Is that Shan's Epic, right? And so the idea was that, you would create a much more efficient system. The laboratory, all the data for a patient would be available to any provider and all that. And all that, I have no problem with that. I think that's great. I think it's exactly the direction we should have gone. But here we are almost 15 years later, and every single healthcare facility I walk into as a patient, they give me a paper form to fill out. Why?
Right.
I mean, yeah, so, and that paper form, I'm sure gets filed away somewhere, or maybe, and I say, why? Don't I have, I mean, these are even within my own hospital system. So they're all on the same electronic medical record, but no more of that. So there should be assured a clear delineation of authority and responsibility at times of a transition. So if they had ordered a platelet count and it still wasn't back, I mean, I think whoever you're transferring that patient to, they should have alerted them that we haven't gotten the platelet count back, so check for that. And then, some systems probably alert providers to new laboratory results and things like that. So this might be a little bit dated in that failure mode. Use discrete endpoints, simply communicate, like if the platelet count returns below 3,000, call hematology. So that if you don't have the result, give instructions on what to do when you get the result back. So it wouldn't just get dropped and the patient not receive the appropriate treatment. Let's see, a couple of other points. This is how we were talking about that. They focused on the UTI, and really we're not seeing the entire picture of the patient and what could have been, and what you pointed out, mental status change that they sort of ignored. So yeah, they said the recommendation was they should have put in the transfer, this patient has recently been treated for UTI and presents with mental status change, hematuria, and anemia. That would pretty much summarize the important findings so far. But what they put in was this patient has UTI and anemia. And so that's all the medicine service was treating her for, was what was in the history. And use written and verbal tools to augment the transfer of knowledge. Okay, we'll quickly then go through maybe one more exercise, and that's a 25-year-old woman the history of a pituitary tumor and was admitted with hypernatremia. Because of her previous pituitary resection and radiation, the patient had a long history of central diabetes insipidus and difficult to manage sodium homeostasis. So they were having a hard time controlling her sodium, which can be the case in patients with diabetes insipidus. At home, she balanced administration of DDAVP, which is desmopressin, and free water boluses given by percutaneous endoscopic gastrostomy tube to maintain normal sodium levels. So she was taking the DDVAP and also using water to try and control the water loss from DI. Due to PEG tube dysfunction, the patient was unable to give herself free water boluses for 2 days prior to admission, and she became progressively lethargic on admission. Her sodium, unsurprisingly, was 159 because she was just losing all her water and sodium was accumulating. During her hospitalization, the house staff team struggled with her sodium management, trying to balance DDAVP and free water by PEG tube. On hospital day 3, although the patient was clinically stable, she had a serum sodium level of 131. So, once again, back to this balance. Based on this result, the intern did not want her to get additional DDAVP that day, as it would lower the sodium even more. DDAVP prevents water loss. The intern wrote the following order: hold DDAVP tonight. Do you see a potential problem?
What's a normal sodium?
135 to 145. Yeah, so say again. Oh, did not want her to get additional DDAVP that day. Okay. Hold DDAVP tonight. That's part of it. That's a big part of it. It's kind of a non-specific sort of instruction. It's an instruction that can be interpreted more than one way, right? Hold that one, or stop giving DDAVP tonight and don't give it anymore. And that turned out to be the crux of the problem in this case. At this center, a medical center policy stated that orders to hold medications are to be interpreted as discontinue orders. If a doctor writes hold, that means discontinue it. Don't just hold that dose, hold it until you get an additional order. So that speaks to that ambiguity of what the doctor wrote: hold DDAVP tonight. Thus, the medication was discontinued in the MAR, and in the pharmacy records, the intern was not notified that they had discontinued DDAVP. Well, you say, well, why would they be? I mean, they ordered that it be held, but they didn't realize that if they ordered it held, then it was going to be discontinued. So it probably, they probably didn't have the habit of notifying physicians when a medication was discontinued.
Policy discontinued when the doctor says hold, the doctor should know. Needs the wrong terminology.
Yeah, it was an intern, wasn't it? And they may not have been aware of it. And that's obviously a failure point. If you have a policy that requires you to interpret something a certain way, you got to make sure people know it so that, so this kind of mistake doesn't occur. The next day, the patient's sodium level rose to 144, which is upper end of normal. In the afternoon, the team wanted the patient to receive her DDAVP. The intern assumed that the patient would receive the evening dose because her order, I guess it was the she, had stated to hold it for 1 day or hold it that night, which I guess she meant as 1 day. The patient was not given DDAVP, and the following morning her sodium went up to 154. She was lethargic and less interactive and was given an urgent dose of DDAVP. Her sodium level was closely monitored for the next 24 hours, and she didn't have any serious long-term consequences. So the adverse event here you know, it wasn't fatal. It wasn't really, didn't cause any serious harm, but it's just an inefficiency of medical care when you don't understand why the patients are responding the way they are and treating it effectively. You know, so and the potential for danger is huge. So the systems processes involved in this incident, well, I think we've mentioned some of them. The hospital policy, which obviously didn't get communicated. Maybe she was a new intern, but I mean, perhaps it's ill-advised to allow interns who haven't been completely familiarized with all of the hospital policies. But, you know, it kind of strikes me that policy was probably buried somewhere, like in a pharmacy policy, that they said, well, if we receive a hold, we're just going to assume it's hold indefinitely unless we hear otherwise. And so you wonder how effectively that policy had been communicated throughout the system. Other systems, I don't know, you have any thoughts on that? What else might have been a failure point here? I mean, the labs were all done correctly.
Somebody had to interpret hold for tonight as hold.
Yeah.
So somebody else
Mhm.
interpreted the doctor's order.
Mhm.
And that's a big failure
Yeah.
there.
You know what strikes me, Ramona, in the lab, you know, we have this readback requirement when we report something that's critical, something like that. And, you know, I wonder what other services have a readback requirement when, you know, an order is given that involves medication or something to make sure that they understand exactly what you meant as far as, I don't know, just a thought, you know, but that was a communication breakdown because the nurse interpreted it differently than the intern intended it, and possibly for a variety of reasons. And the other thing, I guess, you know, they mentioned in it that the pharmacy didn't notify the physician that had been permanent or suspended indefinitely. And maybe that would be a prudent thing for the pharmacy to do, is say, we wanted to make sure that you meant you wanted this discontinued indefinitely.
The internist said hold overnight. I'm a pharmacist. I know that our hospital's policy is hold,
Yeah, hold means stop.
but if
Yeah.
I hear hold and then something, then
Mhm.
I would have to clarify, okay, well, in here, hold means stop, which means that you need to come back tomorrow morning and you need to reissue a prescription for this medication, for this treatment. So if the intern, like, did it go into the notes? Was it an electronic, like you said, an email type failure where it went into an electronic system and someone just saw the hold and didn't read the rest of the sentence? Or did it get, you know, told to a nurse? The nurse is like, okay, well, here, hold means stop. So they need to come in tomorrow and ask for it again. Right? That's a multi-level communication issue in terms of the doctor gave a specific order that said hold for a certain time period, and there was no ground clarification. There was no one who came back and said, okay, but let me define a term for you before you leave. Yeah.
Great point. And I'm going to end with one observation on this case right here, and it goes sort of to what you're saying. I wonder how in the world did that policy ever get put in place? That hold means discontinue. Just doesn't seem to make much sense that, you know, you would say, well, I think, you know, if anybody says hold, we should just discontinue it. And so you can sort of imagine, can't you, that at some point in the past, some doctor had written, you know, hold this medication, thinking that they would discontinue it, but all they did was hold one dose and then continue to give it again. There probably was some harm that occurred because he stopped the medication because it was having some kind of adverse effect. But they put it back in. So they had this big investigation of what can we do to keep this from happening. So the solution was, well, we'll just make, if they say hold, we're going to discontinue it. indefinitely. So they make that part of hospital policy. And it goes exactly to what Richard Cook was saying about complex systems, and modification of the complex systems always increases failure modes. They modified a complex system for how doctors were going to communicate medication orders to the staff. They modified that, and that created another failure point, a way that can be misunderstood or misinterpreted, that whether it's hold that one dose or whether it's hold it indefinitely. And I think it illustrates very clearly what he is trying to say, is that when you investigate accidents, many times, almost all the time, there are system failures that predispose, that create a failure mode and create ways that the system can fail.
Look at the culture itself. So did the nurse actually question the order? Did she feel comfortable enough to actually say something to the doctor? Are you sure this is what you meant?
Yeah.
Is there a not feel comfortable enough to challenge? Well,
Communication is almost always the answer, but we so rarely do it effectively. Thank you all so much for coming.
Does anybody have any questions? We were kind of talking through it as we went. Thank you so much for
Yeah.
coming and speaking for us.
Thank you for the opportunity to come visit my grandson.
Anytime. So we're going to forego a March meeting because everyone will be attending the First Coast Symposium on February 23rd to 24th. And our following meeting will be April 2nd at the Bureau of Public Health Labs. And the topic will be Challenging Pediatric Infectious Disease Cases by Dr. Nizar Maraka. Did I say that right? I hope so. For information on the rest of the schedule, please visit the website at jamsociety.net. Thank you everyone for coming. Oh, Mike from you?
Oh, yeah. Thank you for.
Thank you.
I would have discovered it when you.
I know they're tiny little guys.